Hello everyone. Today what we have for you is a rare tumor found in the head and neck, specifically in the salivary glands, which I'm sure some of you figured out by this first view I have up. So what I have actually is a myoepithelial carcinoma, which is it accounts for about 1 to 2% of all malignant salivary gland tumors, so you can imagine how uncommon these tumors are. So we'll get out of the normal salivary glands. This was more or less to orient everybody and get into the tumor. So these you can actually see in peds, you can see these in adults, but often you're going to see them in people around 60 years old. There's no sex predilection, so men will have them as often as women. But even though I said that these can occur in pediatrics, they're actually really rare in kids. So as we just go around, you guys can appreciate some of the myoepithelial nature. So myoepithelial cells actually have a relatively interesting part in this, but okay, before we get into that, I suppose, how is this going to present? So there's other salivary gland tumors that are relatively slow growing. This is not one of them. This is going to be a rapidly growing mass. It can be ulcerated, and they're often locally very destructive, but they're going to be painless, right? So even though occasionally you might have patients complain of pain in the area, they could even complain of dysphagia depending on which gland is involved or how it's causing some destruction. And you may or may not even see weight loss in these patients. Excuse me. One of the things that's really important to note in their history, though, is if the patient has a history of a pleomorphic adenoma or has multiple pleomorphic adenomas, about half of these cases actually will arise in a pleomorphic adenoma. So that's really something to be watchful for. So even if it's a remote history, maybe this is a little better area to take a look at some of those myoepithelial cells. But yeah, about half of these are going to occur within a pleomorphic adenoma. 3/4 of them are going to occur in the parotids, and the other 1/4 or 25% is going to be made up of the other major salivary glands as well as your minor salivary glands. On imaging, not much to say besides a mass lesion. You're actually going to see bony destruction more often if this is associated with minor salivary glands than the major salivary glands. So keep that in mind. That helps you differentiate very destructive, aggressive tumors in the major salivary glands as well. Grossly, these tend to be well circumscribed. They're unencapsulated. However, this case is kind of interesting in that it is partially encapsulated. Let's see if I can find the border. Kind of shift around here to show you. So we can see that it's kind of partially encapsulated. Then there's areas where the capsule starts to go away. We haven't got there yet. But they're relatively well defined. So they'll have a very nodular or bosselated appearance. I know there's an area where it thins out on here. They tend to be gray-white. Oh, we're getting into that now. So I get back in focus. So kind of here, it starts to disappear. Actually, this is good for talking about a few different things about these tumors. So yeah, nodular bosselated appearance. When you cut into them, like a lot of other lesions, they're going to be gray-white. They have like this glassy appearance, and the glassy appearance is attributed to what we're seeing in this view. So but before we get to that, things that you might see in other salivary gland tumors or metastases to the salivary glands, you're not very likely to see necrosis with this or cystic degeneration. If you do, you really want to think about, is this maybe where they did the core needle biopsy or where they did an FNA? These tumors don't tend to have a lot of necrosis or degeneration associated with them, okay? Sizable, so 2 to 10 centimeters, wide variation in size. Again, most of them are going to occur in the parotid set, and they're rapidly growing. So if you had a lesion, say, involving the submandibular or sublingual glands, those likely would be appreciable earlier on than parotid. Anyway, Getting to the micro, so we're going to again see nodular diffuse sheets. So what you guys maybe appreciated as I was driving around is that we have both sheets and nests within this particular tumor. It's very hypercellular, and here we can appreciate some of the infiltrative growth. I do have another slide to show you some more of that infiltrative growth. The stroma we'll talk about first. So it tends to be either mucoid or myxoid. So that's what we're appreciating more towards the middle of the screen. If I zoom in to 10x and get you guys in focus, you can appreciate that a little more. So on the left, we have very hypercellular areas, very prominent basal lamina or basement membrane. And then on the right, we have these blue-gray, myxoid, mucoid areas. So that's part of your stroma. And what this is made up of is the proteoglycans. Rarely you can see things like cartilaginous matrix, but don't expect to see that. Okay, getting into the actual tumor. So here we have a little bit of the, infiltrative growth, but let's go to an area that has, I did dot an area that had some nice features to show you guys. And I think, yeah, right around here. So these, even though they're myoepithelial cells, and when we think myoepithelium in breast, we think like, oh, they're going to be like more spindled. These actually can show a wide variety of features. So they can be more epithelioid, like what we're seeing here, where maybe they're more polygonal. Let's try to get us in focus a little bit better. They can be spindled, which we'll see in some other areas of this tumor. And another thing that you can see, which I don't think is really appreciable in this tumor, is you can have plasmacytoid areas. So plasmacytoid, you're going to have the eccentric nuclei. It may or may not even give appearance of a perinuclear HOF, so just keep that in mind, but still it's going to be relatively like medium to large size cells. You're going to have fairly abundant finely granular cytoplasm, although you can see clear cytoplasm in these as well, and you can see some bizarre pleomorphism. So what I like about this view is that we have a lot of very similar looking cells. They're relatively ovoid, some of them are more round, but then we have some cells that are obviously bigger than others, some more unusual shapes going on. And so even if you have bizarre pleomorphism in these lesions, which you often will have areas of pleomorphism, it's usually very limited. It should not be bizarre forms throughout the entire tumor. And one of the important things to note is that myoepithelial carcinoma, by definition, does not have ducts. There are some caveats to that. But by definition, you should be seeing the myoepithelial cells. You shouldn't also have ductal components in it. Okay. So other things that you can see as I bring out the other slides so you guys can see a little bit of that is you're frequently going to have mitotic figures, and those can even be atypical. So here we're back to normal looking salivary gland, right? And here we have more tumor, which maybe has some ancient change. Maybe this has been around for a little bit. And here, what's interesting about this view is the dot is right beside some tumor, but we also have the fat that is associated with this excision and with that's probably a better view there. So if I can get that centered for you guys and then get back in focus. Okay. So what we have here is in the center of the screen we have some tumor, right, some malignant myoepithelial cells, and we have some fat encroaching on there. Now, one of the things that you need to pay attention to with whatever excision specimen you have from your surgeon is what they actually took. So even though this is fat, you can see that we still have salivary gland. So we're still within the salivary gland itself. So you should not call this like soft tissue involvement, because obviously this is within the resection specimen itself. You often will see lymphovascular invasion. Here, we're coming up on a little more. There's maybe a better view where you can see some of that coming through, and back to like just this sea of relatively bland. This is even more epithelial, myoepithelial carcinoma. Again, as I mentioned before, you shouldn't really see necrosis, but if you do, that really should be associated with your biopsy site or your FNA site. But what you can see, so even though I said that these tumors by definition do not have ducts, if it is associated with a pleomorphic adenoma, as half of them are, pleomorphic adenoma is associated with ducts. So be careful that you're not attributing areas of pleomorphic adenoma with ducts to this. You can also have carcinoma ex pleomorphic adenoma. That can also have associated ducts. So here, if I zoom in a little higher, we see a little more spindled cells in this view. So by spindled cells, I mean they're more elongated, the ends are slightly tapered, they're not cigar-shaped like we will expect to see in other tumors, but they're not as plump, not as round, not as polygonal. So this one kind of, again, has more of the epithelial and spindled variations, but you can see any combination of spindled epithelial and plasmacytoid, so just keep that in mind. If you have like a lot of squamous differentiation, that's actually very unusual, very rare in these tumors. So if you're seeing a lot of squamous differentiation, maybe think of other entities. Okay? But this is just like here. Oh, and one other thing is, even though like these usually are hypercellular, you actually can have areas that are hypocellular. So if you're worried like, hey, most of this looks very hypercellular, but I have areas that are not, that are focally hypocellular, that is within the range of this lesion. So again, this is a little more epithelioid. So you can see that we do have some areas where it's like maybe there's a little more clear cytoplasm. I do see an actual plasma cell in the mix there, but the cells themselves are not plasmacytoid in this example, but you can see that. Okay, so stains. I did bring stains with me. So things they can be positive for are, well, this is a carcinoma, right? So keratins. So this is an A1, A3. You can see it's diffusely positive, but you could go for more specific keratins, like maybe a CK56. What else do I have? It's myoepithelial, right? So P63 should be positive. So here's your P63, which will go down. Some of you might not be able to see that too well and get in focus. So even though this is not necessarily highlighting everything, this is a nuclear stain for P63, and we can see that this tumor is positive for P63. Okay? Alright, so that's your P63. That can be positive. S100, which is what I'll show next. Look at that. Absolutely beautiful. There's no mistaking that this is S100 positive. Going back to another myoepithelial marker, your SMMHC or SMA. This is SMA, so those can be positive as well. You can see again diffuse positivity. And if you aren't sure, let's see here. So this is normal salivary glands. So you can see the difference within the tumor. So you'll have like there should be like your vessel should be positive, but you get into your tumor and your tumor is more diffuse. Okay, and then to help you out with other things, like you could do Vimentin. Vimentin will be positive. I did mention like the smooth muscle myosin heavy chain or SMMHC could also be positive. GFAP can be positive in this. So this is a C-kit, or sorry, C-kit will be negative, which is CD117. This is DOG1. So if you're wondering about like, is this like some sort of so again, here's our salivary glands. And then if we go into the tumor, we'll go higher power and try to get in focus. So you can see that this is negative, okay? So if you're worried about that, dog 1 will be negative. And I did bring a special stain with me. So what you can see with these is that there can be some PAS positivity. However, you have to keep in mind that it's so out of focus today. Okay, so PAS is also going to stain all those basement membranes. But if you're wondering about something like an myoepithelial carcinoma or EMC, those will have intracytoplasmic mucin. But what we see with this is that it's just that basal lamina, that basement membrane deposition, that is going to be positive. You can have like luminal secretions that can also be positive, but remember, your matrix has a lot of proteoglycan deposition, so that's going to be PAS positive. Okay, for molecular, as we'll go back to the H&E, so you all can appreciate a little more, spend a little more time on this unusual tumor. So for molecular, these tend to have a lot of chromosome 8 mutations, not really set to one specific mutation, but just chromosome 8 aberrations, okay? Other things that you can see are your Ewing sarcoma, so EWSR1 rearrangements. Now remember, the EWSR1 tends to be very promiscuous, so there's a lot of associated rearrangements, but these arrangements, when seen with this tumor, tend to be associated with the clear cell variant. This is not a clear cell variant. I want to make that very clear. No pun intended. But the clear cell variant associated with EWSR1 arrangements, and these patients tend to do worse clinically. Your differential for these, well, obviously we mentioned EMC or myoepithelial carcinoma or adenoma, so that's going to be biphasic. It's going to have ducts. It's going to have that PAS positivity in intracytoplasmic mucin associated. You can think about myoepithelioma, but myoepitheliomas, even though they are, again, tumors of myoepithelial cells, you're not going to have atypia, you're not going to have invasion. Okay, so once you start seeing that, you are out of the myoepithelial realm. Let's see what else we can find here. This one just tends to be very, very epithelioid. Sarcomas that you can think about, right? A very excellent way to go. So leiomyosarc, if you were thinking like, okay, maybe this is more dedifferentiated, that should be S100 negative, GFAP negative, c-KIT negative, and we saw that the S100 in this is extremely strong, so there's no way this can be a leiomyosarcoma. A rhabdomyosarcoma is going to have plasmacytoid morphology, which this tumor doesn't have, at least from what we've seen. But rhabdomyosarcomas tend to be Desmond positive, myogenin positive, myoglobulin positive, MyoD1 positive. So really think about anything that has more muscle specificity. Synovial sarcomas would be another way that you could go. So those, again, are biphasic. This is not biphasic. The molecular aberration is going to be different. So instead of an EWSR1 rearrangement or chromosome 8 aberration, you're going to have a translocation 818. Okay? Or sorry, translocation X18. X18 translocation. So completely different molecular. Those also tend to be TLE1 positive, and again, they're GFAP negative. GFAP, maybe not the most specific stain. I can hear some people groaning internally when I say GFAP, but it is something that you can use. And the other thing that, again, falls into the lines of the rhabdomyosarcoma is if you're thinking plasmacytoma. Plasmacytoma being a lesion of plasma cells, so you're going to have your plasma cell markers are going to be positive, so that's your CD79A, CD138, and there should be kappa or lambda restriction. Okay, this obviously does not have plasmacytoid differentiation diffusely, and plasmacytomas also would be negative for like everything else that we really like for this. So S100, GFAP, SMA, SMMHC, your P63, all of that should be negative for plasmacytoma. Okay. Treatment-wise, they're going to try and do a complete excision on these. So whether that's a parotidectomy, if this is in the parotid, or doing resections for minor salivary glands. If the minor salivary glands involve the bone, then you might have more of a composite resection, so just keep that in mind. They can do chemoradiation, but again, these are very unusual tumors, very rare, so there's kind of mixed results. They don't have great results for saying this type of chemotherapy works, doesn't work, this type of radiation does or doesn't work. For prognosis, these again are very locally aggressive and destructive, so we have a lot of local recurrences, and these can even recur multiple times. So these patients might have excision again and again and again. Distant metastases often occur either later on in the disease course, or they can occur with a recurrence. Okay, and you tend to see metastasis in the cervical region, and then followed by the lungs, and think of other distant areas. So whether that's liver, brain, those kind of things. And about a third of the patients with these diseases, with myoepithelial carcinoma, will die from the disease. Okay? And here we can see almost mid-field, really nice longitudinal folds. But that's what I have for myoepithelial carcinoma. So again, a very uncommon tumor involving the head and neck. And I hope you guys appreciated the simplicity of this tumor, as well as the aggressive nature of it with me. If you like this video, please hit like. Please subscribe if you aren't already. If you have something to add about these tumors, something that I may have missed, something that I misquoted, then please let us know in the comments so that we can all learn from that. And we will see you next week with another short review. Thank you.